Welcome to the very first episode of the California Society of Anesthesiologists' brand new podcast program, conveniently titled Vital Times, the Podcast. I am your host, Ludwig Lin. I'm an anesthesiologist with subspecialty certification in critical care medicine and also have a niche within regional anesthesia. I actually started out in college as a newscaster at my university's AM radio station. So this is, for me, coming full circle. It's pretty cool. These podcasts are designed to further amplify the CSA mission to support and advocate for our members. They will be published on a monthly schedule, and we welcome your thoughts and feedback. Thank you so much. Hi, thank you for joining us today. My name is Ludwig Lin, and I'm one of the podcast hosts for the California Society of Anesthesiologists. Our guest today is Dr. Merlin Larson, Emeritus Professor of Anesthesia at University of California, San Francisco. Dr. Larson started private practice anesthesia at French Hospital in San Francisco in 1970 and was chair there for 10 years. After French Hospital closed in 1989, he seamlessly transitioned to academics at UCSF, and for the following 31 years, he trained numerous anesthesiologists, such as me. Our topic today will be the history of anesthesia, which is one of my favorite Twitter accounts, and incidentally is run by Dr. Larson. So, first of all, Dr. Larson, thank you so much for agreeing to join us. My question for you to get the conversation going is, why should anesthesiologists have some knowledge of their professional history?
Okay, Ludwig, thank you for asking me. It seems like only 2 months ago we were off doing cases together. Perhaps it was longer than that.
Time flies.
Anyway, I'd love to talk about history. You said you're interested. Some people aren't. I mean, it seems like very often I talk to people about history and they start looking for the exit signs and say, oh, I got to meet somebody for coffee. But, let's try to make this interesting if we can. Any profession of medicine is defined by a body of knowledge, and the history of that profession is part of that body of knowledge. So that's answer number one. The second one is, and I could elaborate, I'm not sure if you want to hear it, but we study history to avoid repeating mistakes of the past. And that's quite true in my personal experience. But it's getting harder and harder for me to find somebody old enough to reminisce about some of the stupid things we did in the past. Young people don't want to hear about it. And, I'm old enough that just aren't that many colleagues that I worked with before, but we did some really ridiculous things that we seem to get away with. But that's one reason to study history, to not repeat those things. So now, if you want me to move on to the real answer of why I got interested in history,
Yes, please.
I'll make that transition right now. So I started practice in 1970, and it was a relatively small hospital. We didn't do transplants, major stuff like, heart transplants and that kind of thing. But when I got there, the first thing I recognized is that my job was mainly doing procedures, intubating, starting IVs. And I asked the question, why did I have to have a medical degree to do this? Because the most respected people in the department were the ones that had the most skill at the procedures. It seemed like a technical job, and I just went along with this for a while, which was fine. I was making a decent income. But I asked one of the senior members of the department, I said, why do we have to be doctors to do this? I mean, I don't even know if anybody else thinks about this, but I did, and it bothered me. And the older guy said, look, calm down, Dr. Larson. Just make sure the blood's going around and around and the air's going in and out send the bill and you'll have a nice career. Okay. And I thought about that, and it didn't really satisfy me. So it turns out that French Hospital was very close to two really excellent libraries. One was over at PMC, and one was at University of California. So I went into these libraries and I started reading the letters, manuscripts, and books of the individuals who really promoted in the 1930s for anesthesia to become a medical specialty, not a technical specialty. And these are people like Ralph Waters. I mean, if I go through these names, people may not know who they are, but Arthur Goodell obviously is one of them. And I was really impressed when I read what they had to say. And I sort of felt like they were already my friends when I was reading about, because they were thinking about the same things that I was. So I had a common bond with these people that had died about 30 years ago. They were very enthusiastic about the idea of physicians being in charge of anesthesia. And they had meetings all around the country. This was called the Travel Club. Unfortunately, there were no women allowed, but they had really excellent meetings. And there was a tremendous advance in the 30s and 40s in anesthesia, and partly because of these individuals who brought medical practice into anesthesia. And in the early 30s, basically what you were doing is holding a mask on the face. And by 1950, you had freed yourself from the head of the patient. You had intubated, you protected the airway. We were on the way to getting non-flammable anesthetics. So that was the beginning of my interest in history. It made a major impact on me. I started to think differently about my practice. I thought about each patient, how I was going to do each case as an individual case. Started to get into regional anesthesia. Then I started reading some of the older literature uh, in the Goodell Library that goes back way before 1846 when they started anesthesia ether, and read the accounts of surgeons and patients who described operations without anesthesia. And this is a real revelation because unless you read these, you don't know what sort of a horrific experience it was. And it sort of brought home the importance of what I was doing. And I think that many of us forget about the things we do every day, the miracles that we do. And reading these accounts, like Dupuytren, for example, who was Napoleon's surgeon, he said he was certain that he lost more patients from emotional exhaustion and pain than he did from blood loss.
Wow.
And I mean, there were others that said very similar things. I don't know how many of you've ever read the papers of Henry Bigelow. He was the one that described the first ether anesthetic in 1846, and he was a big promoter of uh, the treatment of pain and stress. And he thought this. He said one of the things he said is, dying is not so difficult, but living with pain is one of the worst things that can happen to a human being. So, I mean, when I read these things, it really brought home the importance of the daily activity and you have to kind of remind yourself of this every day.
Yeah, it
So,
sounds like it really helped to ground your daily practice
yeah,
in almost this sort of sacred history of medicine,
right.
to not even speak of surgery or anesthesia.
Yeah. So that's what these people were doing in the 30s. They were digging back into their medical education and advancing the specialty
Yes.
on what they were doing. So it's like I got to know these people.
I I'm curious whether you ever read any descriptions of what we now call PTSD because these awake surgeries,
Absolutely,
they
absolutely.
must have
I
been
mean,
traumatic.
there's a vivid account of that very thing by a surgeon who had an amputation, and he said that he's really surprised he lived through it, but he had flashbacks. I mean, this is exactly the description of post-traumatic stress disorder. I'm sure that this was fairly common.
No doubt. Wow,
So,
that's kind of chilling,
yeah,
actually.
yeah.
Uh,
So that took place, and then I started to think, this is my job. I'm going in there every day, and I'm going to protect this person's brain from the insult of what the surgeon is going to do. And that's only because I was reading these historical accounts. So
right, right. And I feel like anesthesiology has, through iterations, become more refined. We've slightly changed our goals and our aims. For example, now we think about things like delirium, and perhaps amnesia isn't that great for everybody. But in a way, everything old becomes new again, because of what you're talking about, eliminating anxiety, eliminating pain. There are local feedback loops, there are neuroendocrine connections. Um,
absolutely, yeah.
it's all connected. I don't want to sound new age or anything, but it's scientifically actually kind of sound.
Well, what you're saying is precisely true because I mean, when I was at French in the early '70s, I could go in there every day and give thiopental, Sux, halothane, curare, Demerol, reverse the patient, leave the hospital when they're awake in recovery room, send a bill, and not really consider anything else. And this was wrong because it was just like a routine thing. And that's what I learned about studying the history of why we have a specialty of anesthesia. So,
Yes, that really puts things in perspective. I wanted to ask you a follow up. What are some of the momentous changes in our specialty that you have observed in your own evolution and history as an anesthesiologist?
so this sort of ties in exactly with the discussion we just had. Of course, there are better drugs. We were always worried about health and hepatitis, and of course, there were flammable agents then also. But we're away from that now. So, but actually, the drug advances for me are not that important. Also, the monitors. Uh, when I started, there were no monitors. No EKGs, finger on the pulse, that kind of thing. We did have a blood pressure cuff on, but of course, monitors are great. But I'm going to still get to what I think is the most important change. Um, of course, the monitors. I think the pulse ox is the most important thing. We were doing cases with nitrous oxide and oxygen, hyperventilation, curare, and Demerol. And those cases are amazing. And they wake up, they have no pain. But when we got the pulse ox, we found out that these patients were very often hypoxic. So, I mean, this was a great advance. Okay, surgery is more complex, transplants, really have to dig into physiology to do some of these really complicated procedures. The major change that I see, and I think it's really important, is that in 1970, I was basically chained to the operating room. That was my job. I'd go in and do my thing. Today, we have anesthesiologists all over the hospital. We have anesthesiologists in industry. We've expanded our skills into just various other parts of the hospital. And for example, pain services, ICU, chronic pain clinics, pre-op clinics, ambulatory surgery, administration. And in this change over the last 50 years or more has reasserted our skills and our position as physicians first and specialists second. And this, I think, will continue. I think we're going to have more opportunities outside of the OR. So that is what I would say is the major difference.
Mm,
So,
that's inspiring. I like
mm,
that.
Hmm.
Do you remember any special moments in your own career when this interest in history was particularly relevant or affected a particular case?
Yeah, well, okay. I don't think I ever did this to you, Lid. I was interested in teaching, and I found out very early that residents. It was hard to get residents engaged in history because history questions are not on the oral boards, and I don't think they're really um, on the written boards either. So, in order to engage residents, I would sometimes in the afternoon, when I only had one room, I would tell the resident to go over to the library across the street and go into the basement and find the original description of ether anesthesia. Boston Medical Journal, 1846, November, and the author was Henry Bigelow. So they would leave, and I'd finish the case. And I say, now we're going to talk about this. So, I mean, this worked sometimes. Sometimes it didn't. I think some residents just left and went home. And then, and then they would say, that was very interesting, Dr. Larson. But on the other hand, there were a number of residents that I did that with. And I'd see them either later that afternoon or the next day. And they would say, that was one of the most educational experiences I ever had in residency. And some of these residents that did that was just one trigger that got them interested in history. And it stayed with them the entire career. I still get emails and, they're writing articles. One guy was on the board of the Wood Library, and it started with that afternoon session. And, let me just say about something about that article. The About 5 years ago, the readers of the New England Medical Journal were queried about what they thought the most significant article was in the New England Medical Journal since it started in 1828. And the article that came out on top was Bigelow's article on the description of ether anesthesia. So I'm just wondering how many anesthesiologists have read that most significant article in the New England Medical Journal. And it's fascinating to read and to think about why he wrote the article and then follow up on his career, see what he said about anesthesia.
I'm
So,
going to confess that I didn't do that, and it probably needs to be on my to-do list. It
well,
sounds quite momentous.
I'm sorry, but it is online. Obviously, and there's so much stuff online today, but you can read that by a couple clicks of your cell phone. But there's something different about going to the library and taking the volume off the shelf because you read the article and then you start to look at the adjacent articles to see what was going on at the same time and the advertisements and the stupid things that people were doing in 1846, like bleeding patients. And of course, laudanum was just everywhere. I mean, 10-year-old boy could go in and buy laudanum. So, I mean, that's the difference about the actual volume and looking at it online. So,
Right. Let's move on to another facet of this. We are trying to be mindful of the newer segments of our society that are coming into medicine. And let's face it, women, for example, are a relatively new presence within medicine. You are a guru about history and the history of anesthesiology. There are quite a few famous women uh, academic anesthesiologists. What is your take on the way anesthesiology has developed, and how has it acknowledged and accepted the contribution of women scientists?
interesting question. Of course, that's one of the things I feel bad about. Is when I was chair, I never hired a woman in our department because the surgeons said they would not allow it. I mean, there was tremendous disdain about women even in 1970, and of course before that, even worse. They would never allow a woman to attend a travel club. And even though there were prominent women at the time, Mary Botsford was in charge of anesthesia at UCSF in the 20s and 30s, but she was not allowed to talk about her ideas about anesthesia. Never invited to the travel club. So they were basically treated with contempt. Of course, there was Virginia Apgar, but Selma Thomas knows a lot about that, and she has information that because she was a resident of Ralph Waters in Madison, and that was basically the place to really train. And according to Selma, they treated her very badly there. And it wasn't only until she left and went to Columbia and did the infant scoring system, as well as a lot of other things. That's how we know her. But she really had a fantastic career. Of course, there were others like Mary Botsford, and Stanford had a woman director of anesthesia before Bill Neff came. But they were given very difficult jobs. I mean, there was a surgeon at UCSF by the name of Howard Nafziger, and he wanted to operate in the prone position on the posterior fossa. Well, of course, can you imagine? This is before intratracheal intubation, and he convinced one of the women anesthesiologists by the name of Margaret Wood to go below the OR table and lie on her back and hold an ether mask on the face and spray ether onto this ether mask during posterior fossa. And this is documented. I mean, can you imagine somebody submitting to doing that kind of thing? And apparently they'd have to drag her out under there and put somebody else in there after an hour or so because all the ether accumulated. So anyway, these are the things that the women were asked to do, and the male surgeons would get away with it. I mean, when I'm looking at the history of some of the things that went on in the 20s and 30s, the women were just really pushed around in anesthesia. So Margaret Wood, and then I mentioned Mary Botsford, but Phyllis Amoon at UCSF did some remarkable studies on curare, but she has never received any recognition for it. And I think when
we can
they brought in Hathaway, yeah, you can.
We can certainly honor these women by talking about them. For example, right now, let me pivot to yet another question that I really want to make sure we covered. I chose UCSF as a residency because I knew that some of the faculty had invented cutting edge technology like the pulse oximeter. Let me ask you, what are some of the discoveries that resulted from errors or from epiphany that we now take for granted? What are the things that come, across the top of your head?
Yeah. So there's really two things I could talk about on that. One of them is spinal anesthesia. And of course, the first spinal was done in 1898 in Germany. And that was poorly done because, of course, Beer didn't know how much drug to give. He didn't know the size of the needle. He used a really huge needle. And they had spinals on each other, and they had headaches for several days. And it took a few years for them to figure out that you had to use a fine needle. So that was the first thing. And that was done actually at UCSF in 1900, I think, by Tate and Cagliari. Fine needle, didn't have these terrible headaches with nausea and vomiting. So now you keep going, and they didn't really understand spinal. They started doing spinals in the thoracic area and in the cervical area. They had to learn by trial and error that this was a mistake because patients, you hit the spinal cord, you'd end up with a deficit. Then they started with the total spinal, and that was done at San Francisco General. huge doses. And the funny thing is, it died away, but nobody said that patients died. I'm sure they did. And then you can't believe this, but there was one surgeon who wanted to do thyroid surgery, but he didn't want the drug to go into the brain. And so he would get the needle positioned, and then before he injected, he would have one of his assistants put a tourniquet around the neck while he injected. And he thought that was going to prevent the solution from going into the brain. So these are things that happen. You can't believe that spinal would survive these things, but eventually people figured out that you couldn't do certain things. Some people were doing the spinals in the sitting position and then having them stand up and walk over to the OR table and lie down. Then there was the complication in England, the Rowley and Rowe thing, where the solution was contaminated with phenol, and patients had, sensory deficits. Labat, he was one of the famous regional anesthesiologists in Mayo Clinic. Now get this, when he had a patient with a spinal headache, his solution was to do another spinal and withdraw 25 cc's. So, he would take off more fluid. So, obviously that wouldn't work, but, he was respected and people paid attention to it. Eventually that died off too.
Uh, I actually think we need to wrap this up so that we
No, we
can.
got more to talk about.
We do. We will make that into a separate episode. I think what I would like to do, actually, because I have so many more questions for you. I want to talk about scandals. I want to talk about
Yeah.
the role of anesthesia in like covert operations, and
Yeah. Well,
you
secret
know,
operations, my God, that's part of
yes. Okay,
part
we
of the
will we
career.
will save that for the next episode. But I would like to wrap up this episode by number one, thanking you for taking the time. Number two, let's leave our listeners with some resources to study the history of anesthesiology. Do you have any readily available online features that people could go to start entertaining themselves and educating themselves?
Well, there's really two sources that are main. Everybody that's an ASA member pays a certain amount of dues to the Wood Anesthesia Library. Wood Library of Anesthesiology in Schaumburg, Illinois. It's online. And there's a phone number. The people are extremely responsive there because you're a member of ASA, and they pay the Wood every year a certain stipend to keep the place running. If you've never been there, it's probably the best collection of anesthesia related material in the world, and I think we can be proud of it. But there are two people there that, if you called the phone number, ask for Maureen Ropst and Judith Robbins, and they're very accommodating. They will fax things and send you materials that you want. Of
Great.
course, I'd like a donation, if not mandatory, but so the Wood Library. Then, when the Goodell Library moved over to UCSF digitized a really large number of documents, and they're on the Calisphere, UCSF, and then under search you just put Goodell collection. And I think there's 300 Goodell letters that are online, and there's a lot of stuff on Richard Gill and his trip into Ecuador to bring back curare. So Calisphere, most major training programs have resources like UCSF. UCLA has Bonica's letters. Harvard has Beecher's letters. And then online, Google Scholar, Google Books. Some of these things are free. They're in the public domain. A number of books on Kindle are on the public domain. You don't have to pay anything. So if you have a decent computer, there's stuff right there. You don't have to go very far.
what I
Okay.
really like about our discussion today is I feel like you've grounded it in the reason we're all anesthesiologists. We are physicians that contribute and help these patients in a great moment of need. And
Yeah.
I never actually thought about this, but understanding our origin story really helps to ground that, and it's going to make me respect, our society and our history a lot more after this conversation. I would like to wrap this up. We will have another episode to discuss all the juicy tidbits that we had dangled in front of our listeners. But Dr.
Let me
Larson,
have the
thank you
last.
so much.
Let me have the
Yes,
last word. I'm sorry.
yes. No, go ahead.
One thing I didn't say about these letters in the 1930s is that I did say that they wanted to be physicians first, and anesthesiologists second, but they also wanted to um, improve their image among the rest of the hospital staff. And so Goodell was very conscious of this. He wanted to be nice to the surgeons. He wanted to remember his patients' names if he saw them in the hallway the next day. So, in other words, he said, you're a doctor and you have to act like like a professional. And so that's my final word, physician, anesthesia. That's it. Okay.
I like it. Dr. Larson, thank you so much. And to our listeners, thank you for joining us today. Until next
Okay.
time, take
Yeah,
care.
bye.